Hello all, I'm Professor Dragonillich and welcome to this short video in which we're going to be trying to make sense of bias in research study designs. So this is the typical evidence-based clinical practice process. We've gone through formulating a clear clinical question using PICO. We've been able to search the evidence and now we come up to what people often find the most difficult aspect, critically appraising the evidence. So in order to critically appraise the evidence, we need to have a good understanding of what methodological biases can occur and how we can best overcome those biases. So there's really four main biases that you want to look out for when critically appraising a study, and in particular a clinical trial. So the first bias is selection bias, and that relates to how the participants were recruited and allocated to the respective groups, be it intervention or control. The second bias that you want to look out for is performance bias, which relates to how the interventions themselves were implemented. The third bias you want to look out for is what we call attrition bias, and that relates to the follow-up of participants. So try and identify how many participants dropped out, the reasons why they dropped out, and whether or not that impacts upon the results that were identified at the conclusion of the study. The fourth type of bias is what we refer to as detection bias, and much as the name suggests, it refers to how the outcomes were measured or evaluated. So in going through those four biases, you can see a pattern in that each relates to a different aspect or stage of a clinical trial, or a study for that matter. So recruitment at the start, implementation at the start, follow-up, and then assessment of the outcomes towards the end of the trial. So if you ever get stuck trying to remember those four biases, that's one way in which you can remember it. Just refer to the four steps of conducting a trial. So recruitment, implementation, follow-up, and outcome assessment. So we'll run through how we minimise the four biases shortly, but I thought I'd just quickly refer to a term that you quite often hear when they talk about a randomised controlled trial, that being a double-blinded, placebo-controlled randomised controlled trial. And that what that title is referring to is how researchers have gone about trying to minimise these biases. So selection bias we'll overcome by randomisation. Performance bias and detection bias we overcome by blinding, and then attrition bias, that is the follow-up of participants, we overcome by a particular concept called intention to treat. So we'll run through these four methods over the next few slides. So the first one is selection bias. So as I mentioned, when does it occur? It occurs at the beginning of a trial or a study, and it can occur if people self-select or if the allocation of participants to groups isn't random. So we get an imbalance in the baseline characteristics. So we might have more males and females in a particular group, more diabetics in one group than another, more smokers, people with a higher BMI in one group or another. If we don't start with an even playing field, then any differences that we see between the two groups, intervention and control, really can't be attributed to the intervention. It may be more so attributed to the imbalance at the start of the trial. What it does is, as I mentioned, provides it's an unrepresentative sample of the population, and it affects not only the results but also the validity of a trial. You can have fantastic results demonstrating statistical significance between two groups, but if the methodology is flawed, that is, you're not starting with an even baseline, then what use really are the results, even if they are significant. So how do you overcome? You overcome by randomization, but you also want to ensure that randomization process, or I should say the allocation of participants to one group or another group, is concealed. So what do I mean by that? So let's say I'm randomizing people to group A, which is use of a statin, versus group B, which is use of a placebo. If I know group A are getting statins, during my randomization process, I might be doing that legitimately. But when I see a patient that I think, for whatever reason, would really benefit from the statin, I may intentionally or otherwise allocate them to group A, and then even things up later on down the track. Back in the good old days, when people conducted trials, they would often put the groups in an envelope, which was fine, because people thought, well, who's going to open the envelope? If someone opens the envelope to identify the group, that's obviously going to become evident. But people, being crafty little things that they are, would often put or shine the envelope to the light and be able to manipulate the allocation of participants through that means. So these days, what do? We try and run all of these randomization processes through an external source. Usually we get it done by an independent party, using computer-generated numbers or systems to allocate participants to one group or another. So as I mentioned, performance bias relates to the implementation phase. So trying to prevent, well, in particular, participants from being able to identify which group they've been allocated to. Why is it important? Well, it guards against two things. Firstly, we're able to identify if it is a placebo-controlled trial, so an intervention versus a placebo, we're able to identify the effect of the placebo effect. But it also protects people from dropping out of the study, particularly with drug trials, when they don't know or they can't ascertain whether or not they're taking the placebo or taking the drug taking the drug itself. So not only are we able to identify the efficacy of the drug, but we're also able to identify the effectiveness of it. Obviously, it's not possible to guard against performance bias across all interventions. So surgical, physical therapy, manipulative therapy, education interventions are all types of interventions that we necessarily can't blind against. And so we just have to resolve the fact that there are trials where performance bias is an issue. So attrition bias relates to the follow-up of participants. We're really interested in identifying why data is missing. Take, for example, where we're doing a trial for a particular drug. One of the most important things, apart from its effectiveness, is identifying any adverse events. So if people are dropping out, we want to know why they're dropping out. Is it because they've lost motivation, or is it because of particular side effects that they're experiencing? How is it overcome? Through this concept called intention to treat analysis. Now, I'm not going to run through it here. We go through it in much more detail in year 4. But suffice to say, intention to treat analysis accounts for people dropping out. So if we've started a trial with 1,000 people and only 500 have completed it, we want to identify, or we want to have reasons as to why those other 500 people dropped out. So like I said, is it because they've withdrawn due to lack of interest? Is it due to some sort of adverse event or some other reason? Finally, we've got detection bias. So detection bias relates to the outcome assessment. So again, the researchers or investigators and how they assess or evaluate the final outcomes, and it relates to whether or not these investigators are distorting or manipulating the data in some way. And so you might think to yourself, well, why would anyone want to do that? I'll give you an example. So let's say we're running a trial where we're looking at osteoarthritis of the knee. Excuse the example. Let's say our trial's looking at the effectiveness of a particular supplement versus a placebo. Let's say I am this particular investigator and I'm measuring range of movement. Now, if I don't know whether or not the patient is receiving the supplement or the placebo, I'll evaluate them pretty independently. However, let's say I have got this firm belief that supplements increase mobility, decrease pain, and I am able to identify that this particular patient is indeed receiving the supplements. Whether it be inadvertent or whether it be blatant, I can manipulate the results. So, I might be looking at the range of movement. They can only move whatever percentage or whatever degrees they can, rather than flat out rather than flat out making up the data. I could manipulate the final outcome by encouraging the participant to try and move their knee a little bit more, a little bit harder. They can do it, that type of thing. So how do we overcome that? Again, by blinding. And so it's not blinding the participant, so to speak, but at this stage, at detection bias level, we're trying to blind against the researcher or the investigator from knowing which group the person that they're evaluating was randomized and allocated to, that being the intervention or control. So that's it from me. Hopefully you found that somewhat entertainment and somewhat useful. Feel free to email me if you have any questions. Thank you.